Achha. Good afternoon, students. This is a proud privilege for me to train you from a remote distance. Though we are not together, the feeling is one and the same. I now discuss a very important topic, which is very, very important to you for the undergraduate as well as postgraduate. I will request you to share my presentation to as many friends as possible, because you will be treating one person and making difference in two lives. That is the mother and the child. So that is the way I look at it, and it is my proud privilege to present you the common things first. Don't get afraid. It feels like it is very difficult topic, but after the end of the class and going through one or two times slides, I will be able to convince you that you will definitely be able to treat gestational diabetes mellitus. I must make disclaimer, these classes are done for the benefit of the students from Ukrainian universities and all other students who are not from Ukrainian universities, but look forward to us for learning, to prepare them for examination and practice. It does not give any right, interest, or claim for registration, continuation, and certification by Maharashtra University of Health Sciences or its affiliated institutions participating. Diabetes mellitus, a viewpoint we have, how I look at it, I must tell you. Diabetes in pregnancy can be many types. First thing, the person who has got type 1 diabetes or type 2 diabetes gets pregnant. Secondly, the people who have got pre-existing diabetes and have got the aggravation, or the people who have got the diabetes only during pregnancy. So what I aim to explain the concepts, unless you have the clear concepts, you will fail to differentiate the cases. Because in pre-existing diabetes cases, it is far more catastrophic presentation. While in gestational diabetes, the hyperglycemia is exposed for limited period of time. And that is why there is no so devastating event. So what is just pre-gestational and gestational diabetes? So what is GDM is any degree of glucose intolerance with first onset or first recognition during pregnancy, regardless of whether insulin is used or if the consistency persists after pregnancy. So what is the concept? The concept is there is glucose intolerance, means there is unable to have euglycemic status during pregnancy, or the dysglycemic status noticed during the pregnancy, whether you give insulin or not. That is the concept. Pre-GDM, the pregnant who are having pre-gestational diabetes, these are the ones who have got the diabetes before the conceiving, and whether it is type 1 or it is type 2. So what is the current definition? Why we are more concerned? So women with diabetes in first trimester are classified as pre-gestational diabetes. This is the ADA recommendation 2018. So what they have told, that American Diabetes Association, that if it is found in the first trimester, it is the pre-gestation. Mostly, GDM diagnosed in second and third trimester can be pre-gestational, that is the gestational, and that is the thing you have to identify. The GDM and pre-GDM, both of them have got the transgenerational diabetes risk. Means the baby as well as mother have the risk for having diabetes. So that is the thing you have to understand. Pre-gestational diabetes means the person has diabetes type 1 or type 2 before conception. The gestational diabetes is when the dyslipidemia is noticed during the pregnancy. So both of them have got different connotations. That is why it is important to identify it. I have taken, for the sake of repetition, I have again come back. So what is the risk factors? The risk factor is BMI more than 30 kg per meter square. Previous macrosomic baby weighing 4.5 kg or more. In India, it is not so common to get 4.5 kg, but even 4 kg is we accept as the possibility. Previous gestational diabetes, the mellitus, particularly if the lady gives history or who have got the deranged oral glucose tolerance test. So these are the risk factors. There is family history of diabetes in first degree relatives, when a father and like that. Age more than 25 years, that goes without saying. Ethnicity, you will be surprised to know. The Southeast Asia, particularly India, Bangladesh, and Pakistan, they have got very high incidence of GDM. Black Caribbeans have got there. In Middle East also, there is a certain rise in that. So these are the ethnicity in which the gestational diabetes mellitus is very, very common. History of bad obstetric history, particularly in Indian subset, and the history of polycystic ovarian disease. So these are the ones which are the risk factors for GDM. You will find that if you carefully examine most of the diabetic ladies, you will find very large number of the risk factors prevalent in our subcontinent, and that is why it is wise to screen them. Indian women have got 11-fold increased risk of developing glucose tolerance during pregnancy compared to Caucasian women. So, if you know, this data has again come from the GDM. So that is why we have to screen our population for that. So what is the aim? The aim of maternal metabolism is the baby should get enough nutrients all throughout for its growth and energy. That goes without saying. The baby is the prime and mother is also. So what is the thing happening in the second and third trimester? There is progressive increase in insulin resistance. So why? Because of the placental hormones, cortisol and prolactin. All three increase the insulin resistance. Secondly, insulin-mediated glucose disposal at the skeletal muscles and adipose tissue also goes down. There is huge amount of adipokinins, adipokinopectin, leptin, which again increase the insulin resistance. There is TNF-alpha, IL-6, and resistin also increase the insulin resistance. So what is happening? There is the huge 200 to 250% increase in insulin secretion in late pregnancy. And if it is somehow inadequate, there is GDM. So pathophysiology, what you see in non-pregnant women, there is insulin secretion and resistance is balanced. What is happening when it is balanced in normal pregnancy? Insulin secretion and the resistance is again balanced in spite of having a lot of things are going. What is happening here? There is the ability to produce more insulin and be in glycemia. But in GDM, what is happening? The insulin secretion is far less compared to insulin resistance. And this pathophysiology is causing the GDM. So we understand now the glucose intolerance that develops in women with GDM can be result in their inability to increase insulin secretion. And to overcome, there is resistance that occur even in non-diabetic pregnancy. So this is the thing which is happening. Where is that the insulin resistance is increased, but insulin secretion is not. So you note that. So this is the thing which is happening. So hyperglycemia, what is relevant for mother? If you diabetes related complications can be there. In the high risk of maternal perinatal mortality, poor pregnancy outcome is there. For offspring, they can have the metabolic problem, obesity, diabetes, illegal life. When you tend to look after them, you tend to treat two generations with your single effort. So that is why it is, again, I have diabetes collected from the diabetes care, this photograph. It gives huge amount of opportunity to relieve the two generation of the possible bad outcome. So what is the lifetime limit? How many ladies will have the problem of gestational diabetes, have the problem of having diabetes later? Around 50% of GDM women will develop type 2 diabetes in 5 to 10 years of pregnancy. So that is a very huge sum. Unless we caution them, we monitor them, probably we will lose the game. What are the complications, maternal complications? There is miscarriages in early pregnancy. There is high incidence of infection. There can be preeclampsia, preterm labor, birth trauma, because the baby is large. Assisted delivery is required. Cesarean sections are required. Hypoglycemia is possible due to zealous treatment, or there metabolic complications at DKA if there is infections, or there is the pre-existing macrovascular complications and microvascular complications further to add. There are fetal genesis. There are a lot many things have been noted with the fetal complications in GDM. So what you note is that the anencephaly, sacral agenesis, increased incidence of stillbirth. There is lot many things you can do and to prevent with adequate care. The fetal risk, macrosomia, jaundice, hypoglycemia. Exposure to GDM in utero can have the high risk having GDM and the IGT in 7 to 8 years. And breastfeeding is the silver lining. It can reduce the risk. Maternal risk of cesarean section, eclampsia, recurrent risk of GDM is 30 to 50%. And 30 to 60% lifetime risk in developing IFG, IGT, or acute. So what is the GDM management? The goal is not only perinatal outcome, but also to prevent the long-term maternal and fetal effects. That is why the better euglycemia we achieve, the more and more good outcomes we should expect. And that is the way we look at it. This is the very important thing which is important. What is that? Why we fail in that? Most of the physician and diabetologists and obstetricians don't follow any recommended guidelines in diagnosis of diabetes, GDM. So that is very sad part, and that is many of the I have come across many of the cases who have got bad outcomes, apparently not cared for in time. The dilemmas in management, what are these? Screening to all, early or late gestation, what to do, 1-step test, 2-step test. I will address all of them as we progress, and I am sure you will be able to understand. The screening for GDM is very simple. All Asians at high risk ethnic of having diabetes. Hence, all Indian pregnant women needs to be screened for it. And it is very easy to urine and sugar. And that is very, very good. Then to screen, GDM usually develops in mid to late pregnancy. So after first trimester, definitely it should be. If your screening is delayed till that time, there is chance of missing the pre-gestational diabetes. So the more dangerous thing we miss because the disease is yet to develop, we are doing more harm to the community. That is why what the recommendation now by the Indian diabetologists is that whenever you get a pregnant woman, just do the sugar testing and screen as soon as possible. So which guideline to follow? There are a lot many guidelines, but I will give you the simplest guideline which is followed. So what is there? The ADA 2018 recommends one step. Means you give the GTT, and one stop means you either of the two strategy or uh, what is there in 2 hours you give the 175 grams of oral glucose, and then after screen after 2 hours. Two stop is that 1 hour 50 grams glucose is followed by 3 hours 100 grams for those who screen positive at 1 hour. So these two methods, but mostly one step test is more followed over the India. So what is that? You simply do test at 1 hour and 2 hours at 24 to 28 peak oxidation with women not asleep. So what is that? It should be done in overnight fasting. And what we have to do? We have to give 75 grams of glucose. And then after, you have to take the sugars. And what are the cutoffs? Fasting 90 to after 1 hour 180 and after 2 hours 153 milligrams. Means if 5 mole, 10 mole and 8.5. That is the small way to remember. 5, 10, 8.5. This is the mnemonic I will want to offer you. This is very easily doable. So what is the involved is that the pregnant lady should be fasting for at least 8 hours. She should report fasting. You give 75 grams of glucose. Before that, you take the sugar that is should be less than 92 milligram deciliter, that is 5 mole. Then after 1 hour, it should be less than 180, and after 2 hours, less than 153 milligram deciliter. That is very, very easy. You stop that. What is the advantage? Here you involve non-fasting because it is far difficult to call. So what is there? You have to come, ladies comes, and at 24 to 28 weeks, you give her 50 grams of glucose. And after, if 1 gram glucose after 1 hour, if it is more than 130, 135, what you have to do? C is positive. Then you do 100 gram and 3 hours OGTT. And if it is again values are above the threshold, you are diagnosed. The advantage of two-step is the lady need not come fast. So that is there. So step 2, what are the values? Again, the values are 5, 10, 8.5. So that is the thing. So 5, 8, 8.5, 5, 10, and 8. That is the way you have to. So it is very, very easy to do. And then you can diagnose them at the time. So 5, you take the fasting one, means 95. The 10 millimoles at 1 hour, 1 hour and 9.2 at the 9 at 2 hours, and less than 8 at the 3 hours. If it is there, it is easily doable, and you can remember it, and you can definitely diagnose. So sometimes this question is asked, particularly in the post-graduation. What is the advantage of one-step test and what is the advantage of two-step test? So you must understand, one-step test is the fasting lady required. Two-step test can be done in any time of the day the lady walks in for the checkup. The existing criteria are country specific, but I will come to the best one, that is WHO. WHO says that 75 gram OGTT performed in pregnancy is the same threshold of age. And what is the cutoff here? 140 milligram. 140 milligram above is generally taken as GDM as per WHO criteria. So is there any Indian guidelines? There is question. And DIPSI has suggested it. Again, same thing, which is told by the WHO, and it is very, very easy to do. And what is the goodness of it? The goodness of it, it is more sensitive. You can catch as many babies as possible by the months, and that is why the earlier diagnosis is often. Comparison study, what is there? Nothing great in it, but it has definitely told that the different criteria have got the different catchment. So what is important? Why these criteria have been analyzed in India? For the reason being that the Indian criteria, that is the Southeast Asians, have got good chances. That is why the screening tool should be more robust. And that is why this idea has come. So detection to be performed at first antenatal time, FBT and HbA1c or random groups can be used. If they are suggestive of overt diabetes, means if fasting more than 126, HB or 6.5, you just start. And if results are not suggestive of overt diabetes, you should think of GDM and then again go for the treatment. So this is the chart we follow. Fasting less than 92 OGTM, single step OGTT, and it is over. If fasting 122 to 125, gestational diabetes, and if it is more than 126, it is over. If you find that OGTT again positive, you go for the screening method, and then after the two-step test, and then it is not there, you be happy and you continue. So what is the glycemic target? The glycemic target for in pregnancy is you understand it is very easy to do in Indian subsetting. What is Indian subsetting? That plasma glucose. What is happening? Less than 90 at fasting and less than 120 at the postpartum. You understand it is very simple to do it, and that is why Indian guidelines are far more accepted. Glycosylated hemoglobin has got the challenge because due to dilution, the HB comes down, and more covalent bonding is there. Many times HbA1c is fallacious, and there are limited studies which are available for the authenticity. However, if it is more than 7 in time, it does say it is not GDM, but it is pre-existing diabetes. So that is why it is still advocated to be done in reference. So this is if the patient is SMBG self-monitoring, of course, what they should do, they should keep the goals with them, and it is far easy to do. At the fasting 60 to 90, pre-meal 60 to 90, and after 1 hour of meal 100 to 140, and at late night it should not be less than 60 because we don't want the baby to any time go hypoglycemia. And hypoglycemia, fetal hypoglycemia has got the poor outcome and more incidence of microcephaly. So what we have diagnosed, after diagnosis, what to do? We have to tell the lady that there is medical nutrition therapy, exercise, there is huge role of oral hypoglycemic agent and insulin, which is most physiological. As I have explained you in pathogenesis, how insulin release causes that. And last but not the least is the psychological support. The lady must be given enough psychological support so that the success of the psychological support you explain, reassure, educate, that is very, very important. Explain is very important. Unless you explain the whole process, the whole thing will be understood, not understood. Reassure that enough treatment definitely can have good fetal outcome and good general health and education for the prevention can delay the disease for decades rather than the years. So what is the medical nutrition therapy? It can reduce many of the people, effectively manage 85% of the GDM cases. You can understand there is huge room to help the pregnant lady with GDM with only medical nutrition therapy. 85% people can be effective. So what you have to advise? You have to advise the correct calorie. Now you come to the calorie requirement. The underweight ladies recommended gains are so high. The calorie requirement is very high. That is 36 to 40 kilocalorie per kg body per day. And in normal weight around 30. Why it is 30? Because the nutrition of baby should be also thought. Overweight, particularly the lady, but you have to give little cautious, and very obese ladies, again the calorie requirement has to be understood. In twin gestation, all the calculation above, you have to give 500 calories because the second child also requires the care. Okay, so this is the way. This is the way it is. So weight gain must be explained. The gain of weight has to be explained. It is not that you are gaining too much, you are having the problem. That has to be explained. Advice against attempting weight loss in pregnancy. That is the dangerous thing. Many of the times we are finding some ladies approaching us, I want to lose weight, I am gaining too much of weight, the pregnancy will spoil my career, my outlook. We just discourage this type of thinking, and we have to teach them the correct weight gain, expected weight gain, and how to address them. Obese and overweight women can be advised for moderate carbohydrate and calorie restriction. Medical nutrition goals and recommendation has to be, as the pregnancy progresses, the glucose intolerance keeps increasing. So that is why gradual change is important. And what are the things avoided? First is the sugars, simple carbohydrate, tapioca, carb, potatoes, highly processed food like chips, dairy, juices, high glycemic index foods such as the dates. These are the things has to be discouraged. The small quantity frequent meals is the answer. The more frequently you do, the better. And glucose intolerance has to be addressed at all times. Physical activity, there is the challenge. The most of the ladies believe that they should not exercise because of pregnancy, but it is contrary. The ladies must be encouraged at least 20 minutes daily walk, increase 40 to 60 minutes per day, maintain balance and avoid falls. That is very important because trauma to the abdomen can be disastrous. Avoid contact sports and anything such as which can fall, water skiing, horseback riding. These all should be discouraged. However, moderate exercise must be. I give you this photograph particularly, which is very important, and it is easily doable once exercise. And I have been giving to many of my patients in the practice, and they have really benefited. Coming to the pharmacotherapy, they will come to you, okay, just give me treatment, tablets, and everything will be all right. No, the mainstay of GDM is the medical nutrition therapy. 65 to 70% people will be benefited only for the medical nutrition, by what I explained. Then after exercise, again 10%. Only 10% require the hyperglycemia if they are two GDMs. And what are the drugs? The drugs should not cross the placenta, and the drugs should not harm the baby. That is the two things you must bear in mind while prescribing drugs for the GDM. And that is the most important. Sulphonylureas, it is known that the sulphonylureas, this is the study published. What they have done, it crosses the placental barrier. and it causes hypoglycemia and macrosomia in the babies compared to insulin and metformin. This study has really shaken the medical world not to use the sulphonylurea thing. Telazolidones, again, there is no studies much reported, but it has causes the increased losses to the baby, and that is why it is not. Gliptins, again, not approved for the pregnancy. Alpha glucosidase inhibitors, only 2% increased in the active drug, but it is also known that inadequate safety is not. So that is why it is not much thing. And in otherwise also, alpha glucosidase inhibitors, they are for the postpartum hyperglycemia. They are not universal glycemic agent. So we have to think on that. Metformin has got a huge evidence now collated over the time. It can be used in the studies, and many of the agents centers, they are using it. But it is, what is the goodness of that? It does not cause much of fetal hypoglycemia and less maternal weight gain, and there is high incidence of prematurity reported in some studies. These studies are small studies, so that is why we believe that the metformin has got good opportunity to treat gestational diabetes in resource poor settings. So that is my take, and many of us are using this drug with safety. Insulin is the preferred agent, and that is, it does not cause the central back. Very easy to titrate. And what it does, that insulin resistance as increases, you have got room to increase the insulin. And after third trimester, late trimester, there is sudden fall in insulin resistance. So you should be careful that the lady they should not go in hypoglycemia. So gradually increase in second trimester to third trimester, end of the third trimester, there is sudden fall in the insulin resistance, and then the chances of hypoglycemia. And post delivery, there is again very less diabetes remains, and they have to be taken. So what is that? It has to be individualized. There is no convincing evidence available that which insulin is better than which is not. However, the smaller acting has been used to longer period of time, and that is why it is important. And analogs, the SPART and DISPRO, are approved for pregnancy, but there is very limited data on INSULIN. And Datamir has been approved in pregnancy, and Glargine and ubiquitate is still not approved. So don't be tempted to straight away go to the Glargine or Degludec, because less hypoglycemia reported and single shot is possible. Premix insulin, again, it is used to the success, but the problem is we have to be careful in it. The planning is more important, and premix insulin has to be supported with self-monitoring of blood glucose. And basal boluses regimes are preferred because they give sustained euglycemia and they help with shape long. Intra-partum care, this benefit of vaginal birth should be explained. Induction of labor should be timely, and need of cesarean section to be explained to the lady. And necessary preparation must be done. And if there is preterm labor, antenatal steroid for the fetal lung maturity, preterm labor, early elective birth can be planned if there is something. Last but not the least important is the frequent ultrasound. The fetal ultrasounds must be done, and that is why the baby health must be monitored. As far as possible, there is very interesting story in some parts of India that GDM is an indication for cesarean. Please be sure it is not. It is, I am giving you the details only having GDM is not the indication of cesarean, but many of people are doing it. And what we have can do, the first you assess and you can plan full-term normal delivery, which is very, very possible. But if there is macrosomia, very big baby, 4 kg, 4.5 kg, there is no way except for cesarean. For time of delivery should be done in the 30th week recommended unless obstetric consideration. Poorly controlled diabetes pregnancy, early delivery is recommended. Well-controlled diabetes with good antenatal testing should be continued to the expected delivery date, and they should be continued. And any patient who have got more than 40 weeks complication of free diabetes, it is not. So this is that you should not delay beyond 40 weeks for whatever reason because there are known complications. RSDI guidelines was published. The madam who has given it, many of the slide I have taken from her, it has given the huge recommendation in hospital hyperglycemia, and particularly we have to be careful. Intra-partum insulin requirement, you are knowing that the after delivery occurs, the sugar level may fall. So you be very, very careful in giving insulin around peripartum period. And that is why you have to be. Any boluses are not recommended in the peripartum. Glycemic management during cesarean section, blood glucose normalizes fast, and if appropriate insulin doses, it has been to be given. So short-acting insulin frequently with adequate testing. Immediately after delivery, there is a sharp decline in insulin resistance, and we must do fasting after every 3 days. And we have to see to that the insulin requirement and drug requirement falls. And many, only 15% are remain develop postpartum type 2 diabetes, while many will develop as long as after 5 years of the delivery. That is very, very important. We have to understand. So what is important in women with GDM? We have to weight control, diet and exercise for baby and mother must be explained. We must explain the risk of gestational diabetes and subsequent pregnancy if it has occurred, and screening for diabetes when planning for this pregnancy. We must explain risk of childhood obesity and diabetes in the baby. So these are the issues we have to explain to the patients before. So postpartum GDM management, this is very easily doable thing. What we have presented, and it is every annually fasting plasma sugar, try and TTT, and pre-pregnancy definitely. So these are the recommendation area, which is very, very relevant in managing diabetes. So all pregnant women in India should be diagnosed. So GDM should be done at the time of first week possible. Fasting OGTT should be done as per the policy, and what we have to do, 90-120 phenomenon. Glycemic target not achieved with medical nutrition therapy, pharmacotherapy is indicated, and first week, if the source poor setting, even metformin. If there is enough things are available, insulin and SMBG. And insulin is the treatment of choice because this is the most physiological. And where it is not possible for insulin, for the GDM diagnosis, how to go about that, I have given it flow chart. It is very easy to do and how to go about. I have finished and my slides are open. Please use, share and learn, comment it. I have finished. Any question you can ask. Acha, Ujjwal Kakadia, your question about if gestational diabetes is there, will it not happen in second and next pregnancy? It happens mostly, and that is the thing we have to be careful. That is why in risk factor analysis I have given you, if there is history of gestational diabetes mellitus, we have to be careful in subsequent. What is macrosomia? Iram barbunia. So your question is that macrosomia is the large baby. That is called macrosomia. Okay, I believe I have answered. Anything else? I will share the. Are you getting your this PPT? All of you. BOH, bad obstetric history. BOH stands for bad obstetric history. What is DKA? DKA is diabetic ketoacidosis. Preeclampsia is the state of having high blood pressure and causing maternal as well as fetal complications. IFAG is the that is the fasting glucose intolerance. Fasting glucose intolerance is called IFAG. Advantage of two-step test is that a lady can come anytime, but 75 one-step test has to be done in fasting. So this is the advantage of two-step test. First, the question of you do not understand the second step test. The first step is somebody comes, you do the random, you give her 50 grams of glucose, and then after 1 hour, you screen how much is the blood sugar. If it is positive, you do the two-step test in which you give the 100 grams of glucose, and then after you do the testing after 2 hours and 3 hours. And if it is increased, you straight away diagnose GDM. That is the difference between two-step test. Overt diabetes is what is overt diabetes? The overt diabetes are the cases which are diabetic before the pregnancy is diagnosed. I believe I have answered. Omkar, what is your question? Sorry, pre-gestational, what will happen? So if there is pre-gestational diabetes occurs if the pre-gestational diabetes occurs, the having GDM is not so important. Pre-gestational diabetes means the person is having diabetes before conceiving. So the treatment has to be optimized because you have understood the insulin resistance is increasing in diabetes in pregnancy. So that is why the pre-existing diabetes has to be addressed more scientifically and energetically. What is transgestation? I didn't speak anything about transgestation. Okay. There are no more questions. God bless you all. Do well. Have nice time. And I will be sending the program for next week on Monday. Please bear with me. The 2 classes I have skipped due to occupancy of the hall we will be coming to that. And we are bringing you very good class on tuberculosis by Padma Shri Dr. Alladi Mohan. So this is all coming to you. God bless you. Have a nice weekend.